The Healthcare Labyrinth podcast is back for another episode. Join Mark S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth podcast. My name's Mark Ryan, and it's a pleasure to be hosting the podcast, and thanks to everyone for listening in. Today, we're going to be talking about expected healthcare cuts that are coming out of President Trump's desire to extend his 2017 tax cuts. So I'm going to talk about a few podcasts that I did recently that you could go back to and listen. I'll just give you a brief summary of some of them. Well, on January 10th, I did a 2024 year in review and 25 predictions. I said that I did not think earth-shattering changes will occur to healthcare. Again, I caveated and I said I could be right or I could be wrong. But I did say that I thought that the GOP and Trump may shy away from a master overhaul of healthcare programs, such as tossing the Affordable Care Act in whole and instituting the Medicaid block grants, which are the most far-reaching changes to the Medicaid program. I did say that it's possible that they could use a per capita cap program, and I'll tell you a little more about that when we get into the podcast. Instead, though, I said that the spending cuts package that would be passed for the 2017 tax cuts could sort of sculpt out, as I said, some critical funding in healthcare programs, and that could certainly impact coverage. So please go back to that January 10th podcast to learn more about my predictions for 25. On January 17th, on a podcast, I also covered what I saw was going to be the first 100 days of Trump. And a lot is going on. We have confirmations. We have the new Department of Government Efficiency Commission that seems very dedicated to a fundamental remake of government and programs and regulations. And then I also, most importantly, talked about the mechanism that would probably lead to the passage of these major spending cuts to pay for the 2017 tax cut extension. While the Republicans or the GOP control both houses of Congress, the vote count is very tight. And there are some moderates in each chamber. And regardless of whether leaders and most of the rank and file seem ready to hitch their wagons to Trump and his 2017 extension agenda, it is true that there are a number of moderates in each house that could buck the trend to have major spending cuts. So I did say that it's going to be a tough job to put together a bill, but I did say that I thought that a budget reconciliation bill would likely pass both chambers. And what is that budget reconciliation bill? Well, basically, in the Senate, as many people know, it takes 60 votes to stop debate and to essentially pass a bill. Right now, Republicans only have 53 votes. But there is an obscure provision called budget reconciliation where a bill can pass with 51 votes in the Senate. And so to overcome the tight margins in the House and the Senate, and to not have to get 60 votes on a budget bill, you could fashion a budget reconciliation bill that passed with just 51 votes in the Senate and a majority in the House and get the job done. Again, how far-reaching those cuts are and whether they have huge impact on healthcare programs is anybody's guess, but I would guess that there will be substantial cuts that will impact coverage. On January 31st, I also had a podcast that talked about Joe Biden's two main healthcare accomplishments. One was involving coverage and how he promoted Medicaid expansion, as well as Affordable Care Act exchange enrollment. And also he championed Medicare drug negotiation. So you can go to the January 31st podcast as well to hear more there. So again, January 10th podcast for my 25 predictions and talking a little bit about expected healthcare cuts. January 17th, the first 100 days of Donald Trump's new administration. I particularly talk about budget reconciliation there. And then on January 31st podcast, coverage in Medicare drug negotiations, two main accomplishments of the Biden administration. So I tell you all this because today's podcast is really going to get into some of those possible healthcare budget cuts. And it's a fairly lengthy list. We won't go into great detail, and we'll divide it up as we always do as well. First, as I've sort of alluded to, I do think coverage will be targeted. So let's get into some of the overview right now of what those budget cuts again could look like and where the cuts would come from. So the DOGE, or the Department of Government Efficiency, Donald Trump and congressional GOP lists will likely be culled from various sources, including governmental authorities and outside conservative think tanks. The lists that I will cover in the podcast include proposals from the Congressional Budget Office and a number of other changes not on the recent CBO list from these other government and conservative think tanks that are external to government. Not all are likely reductions, and some of them I have included because I think they would not impact coverage but help reduce costs overall. But I include this entire list here so that everybody can really see what the greatest number of possible cost-cutting scenarios are. We'll divide the podcast up into 3 segments here. We'll take our first break coming up shortly, and after the first break, I will cover overall in commercial and employer coverage. After our second break, we'll cover Medicaid and Affordable Care Act or exchange coverage. And after our third break, we will cover Medicare coverage. Remember that on the campaign trail, the president-elect seemingly took cuts to Social Security and Medicare off the table, although a definition of a cut is nebulous. As an example, are provider or health plan rate cuts or related reimbursement reforms true cuts in lawmakers' eyes? Or is this limited to direct impact on a beneficiary? So I do think that we could have Medicare reductions nonetheless. Before we get to the details again, I would also note that you should not assume Medicare Advantage will not be impacted just because of Trump's declaration on safeguarding Medicare and his perceived friendliness toward MA. The tax cuts likely will mean savings will be taken from MA. What's more, there is a growing alliance between congressional Democrats and so-called anti-corporate welfare Republicans that will help drive Trump toward MA reforms as well. Further, prominent conservative think tanks have also called for MA reform and accountability. In the end, MA won't be safe given the drive for savings and numerous groups singling out MA for reductions. So with that, we'll take our first break, and when we get back, we'll cover some of the overall spending reductions that might be on the agenda, as well as the commercial and employer coverage world. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Mark Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Mark dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Mark is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Mark's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We are talking about the possible cuts that could occur in Congress at the behest of President Trump for passage of a major 2017 tax cut extension. So we promised you that we'd be talking about general healthcare reform first and also cover some commercial or employer group coverage potential reductions. So again, as I note, there's a lot here. I'm just going to do sort of quick bullet hits on each of these possibilities in each of these categories. So again, general healthcare and commercial and employer group cuts first. Well, it is possible that Trump and Congress, the GOP leaders, could begin migrating away from employer coverage to individual coverage. This is something that is very much favored by many conservative think tanks out there. Number two, there could be direct assistance for healthcare insurance purchases and health savings accounts expansion for that individual coverage option. Number three, partial or full removal of employer health insurance tax deductibility in the corporate and individual tax code. That's a big concern of many conservative groups because they argue it drives up the cost of health care. Number four, true investments in affordable universal access. That's one of mine because I believe that could actually cut the cost curve over time. Number five, medical service price reform, including national or regional price setting across lines of business and conversion to value-based care or VBC payments. That's, again, one of mine. I really feel like that drives up the cost of care in the system, and we need to really have some price reform and do it regionally or nationally. Related, I think drug price reform for retail and medical could also occur. This could include many different forms, national or regional negotiations and price setting across lines of business, reimbursement reform and conversion to value-based care payments, patent reform, distribution channel reform and transparency, rebate reform and pass-through of lowest net price at the point of sale, advertising and marketing reform, and drug importation. Number seven, reference pricing throughout the healthcare system. Reference pricing is when you agree to cover a certain amount of a cost of a service or at a given provider. And if somebody goes to different services or providers, they would pay 100% of the difference out of pocket. Number eight, remove restrictions on physician-owned facilities. Many argue that that would actually reduce costs because hospitals would no longer have a stranglehold on many facilities and services. Number nine, fraud, waste, and abuse investments across all lines of business. The problem here is that you're very much shooting in the dark, even if you have a whole lot of resources there. Number 10, major pharmacy benefit manager reforms, especially payment and contracting reforms. Number 11, extends negotiated drug prices in Medicare to commercial. Number 12, direct negotiation via trade with drug makers. This is something that Donald Trump could very well do with his tariffs plan. Number 13, reform the No Surprises Act as arbitrations favor providers and decisions and awards are driving prices up throughout the healthcare system. Number 14, investments in primary care health, wellness, care management, population health, and chronic disease management and education. This is one of mine. I believe paired with coverage, these kind of investments would actually lower overall costs in the system over time. Number 15, expand price transparency and enforcement. Number 16, invest in interoperability. Again, one of mine. If we are able to really invest in interoperability and share data between plans and providers, we could begin to reduce costs. Number 17, long-term care investments and an Aging of America plan, including creation of a robust long-term care insurance market and a public-private continuum of care. Again, what a mind. I think we have to have an aging policy or we will continue to see costs increase both in the long-term care and medical sectors. Number 18, personal responsibility programs and to focus in all lines of business. We do need personal responsibility in healthcare. Number 19, emphasize the right side of care. Number 20, focus on aberrant physician and other provider patterns. And number 21, nursing home staffing mandate repeal, given its huge cost and its infeasibility. Number 22, adopt a voucher plan and slow the growth of federal contributions for the Federal Employees Health Benefit Program. Introduce enrollment fees and minimum out-of-pocket cost requirements in the TRICARE for Life program. With that, we will take our second break and we will come back and start talking about Medicaid and the Affordable Care Act potential reductions.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We are talking about potential cuts that could be in a congressional bill coming up in 2025 due to the desire of Trump and the GOP to extend the 2017 tax cuts. So we're now talking about Medicaid and the Affordable Care Act reductions here. We'll tackle Medicaid here. So number one, there could be establishment of caps on federal spending for Medicaid. This could either take the shape of overall spending caps or establishing per enrollee caps. In essence, these would be the most radical changes to Medicaid, and they constitute either a very restrictive block grant concept or a less restrictive per capita cap proposal. Number two, Congress and Trump could also choose to reduce federal matching Medicaid rates. These could come in a couple of different forms. First, it can include capping administrative reimbursement at 50%, down from around 90% today in most cases. Number two, removing the floor of a 50% match for fairly wealthy states. And number three, moving the higher expansion population match for the Obamacare Affordable Care Act Medicaid expansion from the very high rate of 90% down to regular matching rates. Number three, there's a lot of move toward restricting state taxes and their use on healthcare providers to bring in more federal match. And so that could very well be a major thing because the federal government sees that as very abusive by the states. Number four, eliminating hospitals' nonprofit status. Number five, stricter qualification and requalification requirements in Medicaid. Number six, work requirements for certain populations. Number seven, waiver of benefit requirements for certain populations. Number eight, driving value-based care and payments up in Medicaid. Number nine, remove uncompensated care payments. Number 10, personal responsibility incentives and penalties. Number 11, allow Medicaid program dollars to be used for employer-based coverage. Number 12, limits on long-term care. Number 13, more state innovation. Number 14, expansion of the drug rebate program and inflation rebates. So now we'll move over to Affordable Care Act and exchange reductions. Number one, there could, very outside chance in my view, be the repeal of the Affordable Care Act in converting to state grants for the uninsured, which could be paired with a Medicaid block grant concept that I mentioned above. Number two, sunset enhanced premium exchange subsidies. That will very likely occur. Number three, reform ACA subsidies for both premiums and cost sharing. Number four, restructure exchange premium subsidies to remove repayment limits and further rein in subsidy abuse. Number five, reduce mandated benefits and mandates in exchanges. Number six, separate the subsidized and unsubsidized ACA marketplace. Number seven, appropriate dollars for the cost-sharing subsidies again, which would reduce costs for silver premium subsidies and actually have the government spend less. And number eight, repealing the Biden regulation, which solved for the so-called family glitch. That regulation allows family members to access exchange coverage at some cost to the government in terms of subsidies, and some Republicans want to reverse that. With that, we will take our last break, and when we come back, we will cover some of the Medicare reductions. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Mark Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Mark's insights. Twice a week, Mark publishes a blog to go deep into a current issue. And of course, Mark hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Mark's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth podcast. We are talking about the possible healthcare spending cuts that could be in a reconciliation bill that is meant to extend the 2017 tax cuts. We're back after break 3, and we're going to be talking about possible Medicare reductions. Again, as I told you before, the president-elect at the time on the campaign trail said that he would not touch Social Security or Medicare, but we're talking about it anyway because many people will see provider and other related cuts as allowable under that commitment that President Trump made. So first, we'll talk about the big idea, which would be a full voucher program with set inflationary increases regardless of enrollment in both MA and the traditional fee-for-service program. What this means is that moving forward, while this wouldn't be a reduction per se, the inflationary increase in Medicare over time would be capped, and people would only be allowed a set amount of money each year with inflationary growth. Again, many people would see that as cutting the benefit because people's costs will go up over time, but this is a very popular idea among Republicans. Let's, number two, talk about traditional program reforms. And this is the fee-for-service program here. And we have quite a few of them we're going to go through. So under traditional program reforms, first, we have increased the premiums paid for Medicare Part B. This change would increase the basic Part B premium to cover 35% expected costs for Part B benefits over time rather than 25%. This would clearly violate Trump's commitment during the campaign. Number two, reduce payments for hospital outpatient departments. These changes are various forms of implementing what are known as site-neutral payments. These changes would apply site-neutral payments at both off-campus and on-campus hospital outpatient departments for services that are commonly supplied in physician's office. They would also apply site-neutral payments to all hospital outpatient departments for drug administration. And they would also apply site-neutral payments to all hospital outpatient departments for imaging. And I would note that there's a more radical approach where site-neutral payments would just be across all hospital services and equalizing them with physician offices and other ambulatory service centers. 3 under fee-for-service program reforms are inpatient-only service list elimination. Number 4, removing uncompensated care payments. Number 5, reducing Medicare's coverage of bad debt. The changes either would eliminate recognition of bad debt or reduce the allowable bad debt that Medicare reimburses to facilities. Next, consolidate and reduce Medicare payments for graduate medical education at teaching hospitals. And next, reduce payments for drugs delivered by 340B hospitals. They could also establish a unified post-acute care payment system in the fee-for-service program, as well expand yet simplify value-based payments. The cuts could also further dual-eligible program integration and streamlining coordination, both in the MA and the traditional program. Dual eligibles are people that have both Medicare and Medicaid coverage and consume a disproportionate amount of healthcare costs in each program. So by integrating it and streamlining it, you could have reductions in overall costs in both programs. Last, you could change the cost-sharing rules for Medicare and restrict Medigap insurance. These changes would restructure deductibles and cost-sharing in the traditional Medicare program and establish an annual out-of-pocket maximum, and also restrict the generosity of existing and new Medigap policies in these programs. The idea here is that the Medicare supplement program is too rich and actually promotes utilization in the Medicare fee-for-service program. So by reining in Medigap policies, you would restrict growth in the overall Medicare fee-for-service program. So that's a sum up of the Medicare fee-for-service reductions. I'm next going to go to various types of MA reductions out here, or Part D reductions. So first, on MA rate reform, about 4 things could be done. Reduction of benchmarks across all counties by 10% due to the perceived overpayments in Medicare Advantage compared to fee-for-service. Reduction of benchmarks to no more than 100% of fee-for-service in each county. Blending of benchmarks between county and national costs. And competitive bidding and divorcing the rate setting from the traditional program. On the Medicare Advantage risk adjustment reform front, a number of different things could occur here as well. Congress and Trump could increase the negative coding and intensity adjustment from negative 5.9 to at least 8%, or they could go even farther to 20%. They could eliminate the use of health risk assessments and risk adjustment and use 2 years' worth of data for risk score calculation. They could eliminate the use of manual chart reviews in the risk adjustment process. They could enhance and increase penalties in the risk adjustment data validation process. And they could also adopt stricter risk models. There could also be major MA STAR program reforms, including making the program budget neutral within rate funding. And last, let's talk about Part D changes here. These could include several here. There could be the possible acceleration and expansion of Medicare drug price negotiations and the addition of international reference pricing. There could be expansion of inflation rebates. And there could also be contraction of the Inflation Reduction Act's Part D cost sharing reductions and limits, which are adding considerably to costs and premiums. So with that, those are all of the possible reductions. I'm sure there are others out there, but I gave you dozens and dozens in Medicare, in Medicaid, in the Affordable Care Act, in the exchanges, as well as general reductions that could occur along with commercial and employer coverage. So we'll end this episode of the Healthcare Labyrinth podcast, and we'll see you next time. Take care.
Thanks for joining Mark and the Healthcare Labyrinth podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth podcast.